Sir, over to you, sir. Thank you, sir. Welcome, sir.
Thank you.
Yes.
Anyway, welcome back to the session. Now, today I will be dealing very briefly uh, on the systemic hypertension. We all know that systemic hypertension is a very common public health problem, so-called non-communicable disease worldwide, prevailing worldwide. Now, we all know that the systemic hypertension does not produce any alarming symptoms or signs to begin with. They finally, in a long run, it causes multiple complications in the cardiovascular system. So much so that about 50 to 60% of all strokes are related to the hypertension. Similarly, 30 to 40% of myocardial infarction and cardiac death are related to the hypertension. So systemic hypertension becomes number one predisposing factor or risk factor for the development of the mortality related to the cardiovascular mortality. Okay, so that is very common problem worldwide, but still, because it does not produce any immediate pain or symptoms, the people tend to neglect this disease. Many of the time, the people are not aware of this disease, so it goes unnoticed till the late complication develops. Very easily diagnosable condition, yet goes unnoticed. So the importance is that we all should know how to the ABCD of everything of the systemic hypertension. So I will limit my talk only to the systemic hypertension. Now we all are aware that there are so many definitions available. There are simple things. To call it a systemic hypertension, there should be persistent elevation of the blood pressure. Persistent elevation of the blood pressure. Okay, fine. Higher than the recommended normal range. So now when I say the recommended normal range, currently the trend, I'll come back to that. Previously, for different age, different gender, different those things, they were different levels of blood pressure were to consider to be normal. Now, whenever we diagnose hypertension, it is not a single value which is saying that the patient is having hypertension. It's a persistent elevation. We need to have the number of recording of the blood pressure. Now, before going to the further in systemic hypertension, we all know that blood pressure is the pressure exerted by the column of the blood on the lateral wall of the blood, and we have systolic blood pressure and diastolic blood pressure. Okay. Now, the more the pressure in the vascular system, the blood pressure is more, the heart has to work with the more harder than the normal. So there will be extra strain on the heart and blood vessels. Okay. Now, it's quite common, as I said, it's quite common. About 30 to 40% of all adults will have some form of high blood pressure or hypertension. We have pre-hypertension, elevated blood pressure, hypertension, and so on. The different levels of hypertension is there. So it's a very common disease. So millions are affected worldwide, but only 30 to 40% or 50% are aware of their persistence of hypertension. Even in India, about 30 to 40%, there is no 100% data say that this much is the prevalence of hypertension in India, but approximately about 30 to 40% of the Indian adults are also hypertensive. And the number one cause of the deaths, especially cardiovascular or stroke deaths, are related to hypertension one. So that is one of the important condition leading to the mortality as well. Not only morbidity, mortality as well. Now we all know that if the hypertension, elevated blood pressure, if it is not controlled, it can lead to the various target organ involvement first. Later on, it can lead to the target organ damage. For example, like the heart, the brain, the retina, kidneys, nerves, and so on. So there is more morbidity as well as mortality. Now we also have the various studies worldwide have been done. A number of studies have been conducted, and it has been clearly demonstrated that reduction of the blood pressure, at least 10 millimeter reduction of the blood pressure, systolic blood pressure, can lower the risk of such cardiovascular deaths and even the target organ involvement or damage, whatever it is. The reduction of the blood pressure also has been a strong evidence is there to suggest that lowering blood pressure can reduce the risk of cardiovascular death as well. Okay, fine. So hence, the hypertension becomes the number one modifiable risk for the cardiovascular disease and thereby the cardiovascular death. Okay, fine. Now, some aspect of physiology. We all know that the blood pressure is the product of the cardiac output and peripheral vascular resistance. No? The mean arterial pressure is determined by the cardiac output and systemic vascular resistance. Now, all of them are determinant on the various factors, like maybe tissue factor, vascular resistance, peripheral vascular resistance, and various neurohumoral factors like renin, angiotensin, aldosterone system, which all affect in one or other way to the vascular resistance, heart rate, the contract of the heart, the preload, afterload, and so many things. Finally, now all especially the cardiac output, the heart rate, as we are all leading to the determinant of the mean arterial pressure or blood pressure. Okay, fine. The systolic blood pressure is primarily tells us about the cardiac contractility during systolic period, and it also tells about the elasticity and distensibility of the conducting arteries. Whereas diastolic blood pressure tells about the resistance or tone of the arterioles and viscosity of the blood. Now, having said that, what happens if we do not have an arbitrary level? We know that normal blood pressure, systolic blood pressure should be around less than 120 millimeters of mercury, and diastolic blood pressure should be less than 80 millimeters of mercury. So that is normal. Now, if the trend is going up, if the blood pressure is being elevated for quite a long time, what are the changes that is happening? Now, in the small arteries, that is less than 1 millimeter in size, very small arteries, there is arteriosclerosis develops, and there may be degeneration, occlusions, micro aneurysms can develop, and all these things are the small arteries are there in the end organs, so they tend to develop more end organ damage, like in the brain stroke or the retinopathy, the so many things, and nephropathy and so on. Now, in the large arteries also, they cause significant changes. They produce the intimal thickening, the smooth muscle hypertrophy, so that they are non-distensible. Distensibility comes down. So they all contributes to the development of the complications. Okay. Now, if you understand the physiology of control of the blood pressure, now we have various factors controlling the regulating blood pressure. That may be autonomic nervous system, which includes both external stimulus and internal environment with the help of the baroreceptors everywhere in our vascular system. They can sense. The sympathetic system will interrelate with the endocrine system, especially the adrenal and the renal system, that is the juxtaglomerular apparatus, in which the sympathetic, parasympathetic, the endocrine system, and the renin-angiotensin system, they all interlace one another, with the trigger one another to produce the either vasoconstriction, vasodilatation, to determine the level of blood pressure depending upon the various stimuli. In addition to these named the determinants, there are some specific factors inside the vascular endothelium itself. One is the nitric oxide, which has got a very short acting vasodilator effect, whereas the endothelins, which have got a persistent action of the vasoconstrictor effect. So the endothelial peptide also helps in maintaining the blood pressure. Okay, there's so many things which are related to the maintaining of the normal blood pressure. Now, because without understanding this, we do not know where to intervene, which type, what are these things. So it's very important, essential to know the basic physiological control of the blood pressure as well. Now, so I find this definition very useful, because the hypertension is defined as a complex, it's not a simple disease, a complex disease, multifactorial disease. It is not a one-time disease, it's a progressive disease involving the cardiac and vascular system. So complex progressive cardiovascular syndrome of persistently elevated blood pressure with many causes, not single cause, many cause. Okay, resulting in functional, in a long run, it results in a functional and structural changes in the heart as well as the vascular system. I find this a very, very, very useful definition which summarizes every aspect of hypertension in one sentence. Now, this is given by quite long ago by the working group of the American Society of Hypertension. I still find this definition is very useful to understand the hypertension. Now, we all know that hypertension, initially I said the blood pressure changes with the age. So that's why we say normal range. It may vary from time to time. So, but the prevalence of hypertension definitely is increases with the advancing age. We can see the bottom line, so much so that above 80 years, almost 65% of people above the age of 80 are hypertensive. Their blood pressure is more than the recommended normal persistently. So we can imagine the thing. So some people may have only systolic, elevated systolic blood pressure. Some people may have systolic as well as diastolic blood pressure and so on. Now, the studies have shown that even if you are normotensive at the age of 55, from 55 to 65, the next 10 years, the chance of developing blood pressure is almost 60 to 70%. That means the hypertension is a disease of advancing age. This is a famous long Framingham study, which says that after 55 years, the chance of development of hypertension in about 10 years, that is 50, is almost about 60 to 70%. So it is a disease of the advancing age. Thereby, its morbidity or mortality related to this thing also will be proportionate to the development of the hypertension and its complications. Now, go back to the basics of hypertension. Now, there are so many types and so many classifications of hypertension, which is very useful for your writing the answer book and to understand the concept of hypertension. I'll put this thing this way. The hypertension or systemic hypertension is classified as primary hypertension. We say that 90 to 95% of the hypertension prevailing in the society belong to this category, primary hypertension. Even though we say primary hypertension to begin with, that means we do not know what is the definitive cause for the elevation of blood pressure without any identifiable cause to begin with. But now, because we have so many investigation facility to find out what is the mechanism, which part of the controlling system is gone our way, so we can find out. Finally, now the trend has come that about 40 to 50% of the hypertension, primary hypertension, and so-called primary hypertension, once we evaluate within a span of a month or so, we'll be knowing that there will be some secondary causes as well. So, but textbooks still say that 90 to 95% hypertensions are primary hypertension. There are no identifiable cause to begin with. But as you evaluate, you will be able to. And of course, these people will have genetic predisposition for the development of hypertension, strong family history, multifactorial. Okay, and rest of the 5% or 10% to begin with, they may have secondary hypertension with the definitive identifiable cause. So hypertension primarily classified as primary hypertension and secondary hypertension. We'll come back. Now, what are the contributing or predisposing factor for the primary hypertension? I have told you that hereditary predisposition, advancing age, the prevalence of hypertension at the age of 20, maybe on 2 to 3% or less than 4%. Same thing at the 60, it may be 30%, and about 80 years it is. We have already seen that. So the advancing age, gender, males have got high prevalence of hypertension, and as the females, I mean women, postmenopausal period, the gender equality becomes equal. Ethnicity, some blacks have it, they have got more hypertension than the whites and so on. Socioeconomic status are all implicated in the development of hypertension. In addition to that, now the hereditary predisposition, age, gender, ethnicity, all those things is not modifiable. Okay, but sodium intake, it is said that in certain population, certain subset of the people, maybe a large subset, there may be something called as salt sensitive hypertension. Those people develop hypertension as they increase the salt intake, their blood pressure also keeps on increasing. So that variety is called a salt sensitive hypertension. And various other dietary factors, those are lacking in the potassium or magnesium and so on. And if you ask me, the number one cause of the development of the hypertension is sedentary lifestyle, sitting in sedentary lifestyle. Okay. Now, and overweight, obesity, they're all significant. Smoking, which can induce vasospasm and development of the persistent elevated blood pressure. In addition to that, so many other things like presence of insulin resistant, diabetes mellitus, dyslipidemia, metabolic syndrome, and even the stress, emotional stress, mental stress, whatever you call it is, all those things predispose. So primary hypertension is primarily a multifactorial. Now we can say that sedentary lifestyle, we can modify it very easily, weight we can modify very easily, smoking can be ceased, stress can be relieved. Those are all the things which can be easily help to control in a way of normal, non-pharmacological modification. So that is why to understand the intervene the things, we should know the predisposing factor for the primary hypertension as well. Now, a very common question, very fond question in the Viva as well as in the theory, what are the cause of secondary hypertension? There are so many things. Primarily, when we say secondary hypertension, there is a definitive cause. We may think it is renal because renal organ, endocrine organs are the primary controlling system. Autonomic nervous system, renal system, and endocrine system are the primary controlling system for the blood pressure. So if there is an abnormality there, they can lead to the hypertension. Like renal, we have renal vascular and renal parenchymal causes. Renal parenchymal causes like glomerulonephritis, both acute and chronic glomerulonephritis, both acute and chronic renal failure, kidney disease can lead to the hypertension by various mechanisms. Similarly, renovascular hypertension, the vessels, the renal arteries are stenosed or occluded due to any reasons, like maybe atherosclerosis in advanced age, fibromuscular dysplasia in young females, or renal artery stenosis due to any other cause, vasculitis, anything, they all can lead to the hypertension, trigger the renal mechanism and produce renovascular hypertension. Okay. Now, endocrines, now we have plenty of conditions like right from the hyperpituitarism to the Cushing syndrome, pheochromocytoma, all dysthyroidism, both hypo and hyperthyroidism, everything can lead to every endocrine organ dysfunction can lead to the hypertension. But most common, the current thing is the hypothyroidism is very often missed. Very common cause for the secondary hypertension. It may behave like a mild hypertension. You find the patient hypothyroid, you treat the hypothyroid, hypertension resolves. So that is all important things. Okay. Now we have yet another class is the drugs. Very often we tend to give NSAID for various inflammation, various joint inflammation or pains and arthritis and other things. Very commonly they produce NSAID, OCPs, OC pills, especially in a patient with renal failure, erythropoietin, so on. Pregnancy can induce hypertension, coarctation of aorta, sleep apnea. That is another common factor which is commonly missed. Obese patient, thick neck, and the snoring patient, if you tend to fail to ask the history, sleep apnea may be missed. One of the very commonly encountered now because of the increasing trend in the obesity, overweight and obesity. Sleep apnea is one of the important causes for the secondary hypertension in the current day. Okay. Now, when do we suspect? We have said that 90% of the hypertension were primary hypertension to begin with. But when do I suspect secondary hypertension? Now, onset of hypertension before the age of 20 years or onset of hypertension after 55 years. First time recognition of hypertension, labeling of the hypertension before 20 years or after 55 years, we need to think that are there any secondary factors, whether it's renal factors or endocrine factors and so on. We need to find out. Similarly, severe, in other words, primary hypertension usually occurs between the age of 30 to 45. So given some question, so, okay. Now, primary hypertension is very easy to control, whereas if there is a secondary cause, like say, for example, renovascular occlusion, renal artery occlusion, or a hypothyroidism, or pheochromocytoma, in spite of you give multiple drugs, hypertension will not be controlled. So very severe hypertension to begin with, or difficult to control hypertension, you suspect you need to think that there is secondary causes. Previously controlled now I have a primary hypertension. I have a patient with primary hypertension, very well compliance on the medications and drugs. But after 5-6 years of very good control, suddenly the same person developing uncontrolled hypertension while on drug. That means previously controlled hypertension getting uncontrolled all of a sudden, think of a secondary complication or secondary vascular occlusion, secondary thyroid problem or something like that. Think of secondary hypertension. Initially I said hypertension do not manifest with the symptoms and signs. They may come with complication. Many of the people come with the cardiac myocardial infarction or cardiac failure or stroke without any previous history of hypertension. Now in such condition, you think that there is secondary factor in the development of hypertension. Sometimes we come with the obvious features. like hypopituitarism, hypothyroidism, Cushing syndrome, few, and renal bruit. When you examine, the renal bruits are there, palpable kidneys are there, other features of CKD are there. So you think that specific features secondary disease there. So you say that that's definitely a secondary hypertension. Now, why it is important? Now, if you find out the cause for the secondary hypertension and you can treat that secondary cause, the hypertension can be easily controlled or even sometimes cured. So essentially, again, one of the very commonly asked question for the UG students are, how do you differentiate primary to secondary hypertension? As I said, the common primary is very common, 90 to 95%. Secondary is very rare. Onset between 30 to 35 years, between 30 to 45 years, whereas secondary hypertension, most of the time, either before 20 years or after 55 years. And primary hypertension patient remains asymptomatic. So 90% of patients remain asymptomatic, whereas secondary hypertension will be most likely they will be symptomatic. And there are no definitive cause for the primary hypertension, and definitive cause easy to control in the primary hypertension, very difficult to control. The complications are relatively late in the primary hypertension, whereas secondary hypertension, because the uncontrolled hypertension, persistent elevated or long-standing hypertension, the early complication in the secondary hypertension. Now, if you know what is primary hypertension, secondary hypertension, when to suspect secondary hypertension, then we need to find out what are the different stages of hypertension. Now, the Joint National Committee for Prevention, Detection, and Management of Hypertension has given the criteria. The normal blood pressure has been said, systolic blood pressure, anything less than 120 millimeters of mercury is normal, and diastolic blood pressure of less than 80 millimeters of mercury is normal. Now, pre-hypertension, this is in the JNC, Joint National Committee, the systolic hypertension between 120 to 139 and the diastolic between 80 to 89 is a pre-hypertension, and stage 1 hypertension is 140 to 159 and 90 to 99 of the diastolic, systolic. Now, and stage 2 is anything above 160 of systolic blood pressure and anything of more than 100 millimeters of mercury of diastolic blood pressure is called as hypertension. Now, if the patient has got, when you are considering patients, for example, a patient has got BP of 150 by 80 millimeters of mercury. Now, I consider the highest abnormality, that is systolic pressure is higher than the category. Now, the 80 millimeters comes to the normal, whereas 150 becomes the stage 1. So whichever the higher value I take, it is a stage 1 hypertension if it is persistent for a long time the same way. Or if the patient has got 130 by 100, now we know the 100 becomes the diastolic blood pressure is the higher value, higher stages than the systolic blood pressure. So I take the stage 2 hypertension because the diastolic blood pressure is 110. So both systolic and diastolic need to be considered for the staging of the hypertension. Whichever is the highest, you consider that stage. Okay, fine. Now, in 2017, the American Heart Association and American Cardiac Association have come with a common guidelines, modified guidelines for the categorizing the BP in adults. They say again, normal, to call it normal, systolic should be less than 120 and diastolic blood pressure should be less than 80. That is as in the JNC. But the pre-hypertensive category has been removed and they made it as elevated blood pressure. And again, you see the difference. Pre-hypertension was less than 120 to 139. Now here they have made elevated blood pressure to 120 to 129. And diastolic blood pressure, again, it has become less than 80. That is elevated blood pressure. So only systolic blood pressure between the 120 to 1. Now, if you take this category, now any one of us, if you record, I believe that we all will be in the elevated blood pressure category. Most of us. Okay, fine. So when do you say hypertension as per the AHA guidelines, recent guidelines, stage 1 hypertension, any blood pressure more than 130 to 139, between 130 and 139. In JNC categorization, this was pre-hypertensive stage. Now it has become hypertensive stage 1. Numbers have come down. So if we include this, I think about 60% of the population in India will be hypertensive right now. Okay. Now the diastolic blood pressure in the stage 1 is 80 to 89 millimeters of mercury. Now see that in the first normal and elevated, that is and systolic and diastolic, whereas in the hypertensive stage, it has become or. whichever is you can consider. Stage 2 is anything above stage 2. Previously it was stage 1. In JNC, it's stage 1. Now it has become stage 2 hypertension. Now why they have drastically reduced these numbers? The numbers of blood pressure, the cutoff value have come down drastically, more than 20 millimeters now. Why? Because they have found out that even so-called pre-hypertensive stage, see the pre-hypertensive stage 130 to 139, 80 to 89, even in such patients, because they were not being treated, the chance of them developing the cardiac and cardiovascular and stroke incidents are much higher than the so-called normal hypertensives. So the experts have thought that they should bring the pre-hypertensive stage into this category. Okay, fine. Now, as I said, there are so many recommendations, so many societies which are coming up, but the Joint National Committee reports are the one which is being followed worldwide very commonly. Now, recently, as I said, 2017, American College of Cardiology has come with the newer guideline, which I have already told you the classifications. They have recommended the various aspects of the, right from the recording of the hypertension to management of the hypertension, monitoring of the, everything has been come up in a beautiful way. Now even Indian Society of Hypertension, we have Indian Society of Hypertension, which has come up another guideline. So each regions have got their own guidelines. Now, if you go by the Indian Society of Hypertension, the guidelines are entirely different. Now, this is a recent one, 2017, 2018 one. The grade 1 hypertension is systolic blood pressure between 140 to 159 and diastolic blood pressure of 90 to 99. And grade 2 is 160 to 179. Grade 3 hypertension, there is a grade 3 also in Indian guidelines. And we have some more guidelines saying that isolated systolic hypertension with the blood pressure, only systolic blood pressure is more than 140 millimeters mercury, where the diastolic blood pressure is still normal. And we categorize hypertensive urgency, very asymptomatic hypertension with the systolic blood pressure more than 180 and diastolic more than 120. That was there even in the JNC category, and hypertensive emergency, so on. So there are so many guidelines, but we all follow ideally the JNC 8 guidelines. Still, we are yet to implement the AHA 2017 guidelines. Okay. Now, what are the symptoms? So there are so many arbitrary numbers. So we go by, still we go by the JNC 8 category. Okay. Now, there are so many symptoms of hypertension. What are the symptoms of hypertension? 80% the primary hypertension will remain asymptomatic till they develop advanced hypertension. They already developed some complication, vascular remodeling has occurred and some complications have developed. So, and they land up with the complications, morbidity, mortality, and so on. So that is why the hypertension is called as a silent killer. The heating has started already, but unless it boils, it will not produce smoke. Similarly, the hypertension will remain asymptomatic till they develop some complication. It's most of the time, many may experience easy fatigability, decreased activity tolerance, that effort tolerance may be decreased, or dizziness, especially on getting up from the squatting position or bending for a long time. They may develop dizziness. These are the common symptoms. Again, palpitation, exertional breathlessness, exertional angina, and occipital headache, early morning occipital headaches are some of the symptoms, but only in minority of the patients in the primary hypertension. Okay. Now, signs. Do we have signs? Yes, we definitely have a sign. What is this important sign? We know that recording the blood pressure itself is a significant sign. In a proper way, we need to record the blood pressure. Okay. If they develop additional signs, that implies that they have developed complications of hypertension. So only problem is hypertension initially can be recognized only by a very simple method of recording blood pressure. We say that blood pressure is more than that and this particular time, this arm, this position, all those things you brand it. On several recording, you say that hypertension. That is the only sign, but there may not be any other sign. But if they develop sign of anything, it indicates that hypertension was there for a long time and that has already caused target organ involvement or damage. Okay. Now, there may be cardiomegaly because heart has to contract more vigorously. So initially there will be forceful apical impulse. The aortic component of second sound will be loud. There may be ejection systolic murmur, and later on they may develop cardiomegaly, indicating that heart has been involved. And there may be features of retinopathy. Those who can look at the fundus, they will see the features of retinopathy, and there may be features of heart failure, cerebrovascular accident, so on, or renal failure, and so on. Now, in addition to that, we need to find out, are there any pointers to the secondary hypertension? Even in a patient with the primary hypertension, there may be a secondary component. To begin with, it may be primary hypertension. They may develop a atherosclerotic process, because hypertension and atherosclerosis go hand in hand. Lipid tension, lipid disorder and hypertension go hand in hand. They develop accelerated atherosclerosis. They may develop atherosclerotic occlusion of renal artery. So you may, in a primary hypertension, may go on to the secondary hypertension, may have the superadded element of the renal artery hypertension. So you need to look for the renal bruit or renal features of renal failure, features of hypothyroid, Cushing's, and so on. Okay. So diagnosis of hypertension is very simple, very simple. Even a trained non-medical person also can recognize blood pressure. If you can train the patient, they also can recognize the record the blood pressure. So that has to be done by everyone. So accurate assessment of the blood pressure in an appropriate way, recommended way, is the key to the diagnosis of hypertension. That is very critical in screening for hypertension, community screening of hypertension, as well as the appropriate management and monitoring of the hypertension. Okay. Now we have office hypertension. The way, what people call the office hypertension is recording the blood pressure in the hospital setup, in the clinic setup, by the doctor or a paramedical staff. All of them are considered as a office blood pressure. Home blood pressure means the recording of the blood pressure by the patient himself or the family members inside the home, in the house, in their normal relaxed atmosphere. And we have one more equipment called as 24-hour ambulatory blood pressure monitoring. That is, we deploy the blood pressure cuff, run for 24 hours, and record it continuously, very episodically, every 15 to 20 minutes or 30 minutes, record throughout the day and night for 24 hours. So these are the equipments we have. Now, how do you record office blood pressure? Of course, now the mercury sphygmomanometer is banned. If you use it, very good. Otherwise, a Renoid BP apparatus or the digital current day, the digital blood pressure monitoring systems are available. It should be calibrated. It should be calibrated periodically. It should be accurate. Okay. Now we know how to tie the blood pressure cuff. It should be tied to the arm 1 inch above the cubital fossa. When we select the cuff, we should look for the arm circumference, and we should know what is the circumference or the size of the bladder inside the inflatable bladder inside this cuff. There are different sizes of the cuffs are available. If you do not use appropriate beefy cuff for the appropriate size of the arm, the recording may be abnormal. For example, a pediatric patient should require a smaller cuff. The cuff should encircle, the bladder should be encircle 80% of the circumference of the arm. That is the recommended standard. So for recording the thigh, you may require a larger cuff. For recording in normal adults, the normal adult cuff. So they are quantified as a small cuff, medium cuff, large cuff, and extra large cuffs for the current obese patients also. Okay. Now, we should record with the appropriate way. What is the appropriate way? The recommendation is that, no, I think I have slide. Okay, fine. The patient should be seated comfortably, or it can be recorded in the supine position also. But patient should be comfortable in this position. If sitting, the back should be rested and feet should be flat, touching the ground. Even when the patient is supine, they should not be crossing the leg. The leg should be parallel. When we tie the cuff, make sure that the tubings are in the front. So that when the tubings are connected to the bladder, the tubings are nothing but extension of the bladder. So they should be in the front. And they should be about 1 inch above the cubital fossa. The tying of the cuff should be appropriate, tight enough. They should not be loose, freely mobile, and it should not be extremely tight. They should allow a small finger to interject between the cuff and the arm. And you should look for the pulse, both radial pulse and cubital pulse, palpate first. The arm should be rested. If the patient is sitting, arm should be rested on the table in front. It should not be hanging. Arm should not be hanging. Even in the supine position, arm should be rested. Arm should not be hanging or elevated. Okay, those are some prerequisites. In addition to that, patient should not have consumed coffee or should not have smoked, should not have walked for 30 minutes period of recording blood pressure. Those so many preconditions are there to record the appropriate recording of blood pressure. And the recorder should find the record the blood pressure by the palpatory way first, systolic blood pressure. The inflate the bulb, inflate the cuff, and look for the occlusion pressure. As we palpate the radial pulse and inflate the cuff, at particular pressure, the radial pulse will become occluded, radial pulse will become absent, further elevate by 30 to 40 millimeters and gradually deflate at the rate of 2 millimeter per second. 2 millimeter, very gradual reduction should be there to find out. So reappearance of the pulse indicates systolic blood pressure by palpatory method. Now completely deflate, again reinflate 30 millimeters above the previously palpated the systolic blood pressure by palpatory method. And with your diaphragm of the stethoscope on the cubital fossa, again reinflate and gradually deflate with the rate of 2 to not more than 4 millimeters per second gradually. The appearance of the coroscope sound, when, because it is a partially occluded, as you deflate the cuff, the external pressure is becoming reduced, the pressure becomes, the blood pressure, the column pressure can overcome the external pressure and able to pass down that pulsatile way, producing a coroscope sound. That is the appearance of coroscope sound is a systolic blood pressure, note that, and gradually reduce. Gradually, there may be, because of the pressure changes, there may be muffling, there may be some attenuation and other things. Finally, at some point, the external pressure is no way hindering the arterial compression. So there may be the coroscope sound will disappear. That is the stage 5 of coroscope sound, and that is recorded as diastolic blood pressure. Okay, fine. We all know that. Now, once we record in one upper limb, you should record in the another upper limb. If there is difference of more, there should not be a difference of more than 10 millimeters of mercury. If there is a difference of more than 10 millimeters of mercury, that is abnormal. Okay. Now, whenever we have a higher blood pressure in one upper limb, say left upper limb is 130 by 80, right upper limb is 138 by 86. So we note that higher blood pressure, whichever, that arm should be used for the further monitoring. Okay. And if there is a difference of more than 10 millimeters, you should always record the blood pressure in the lower limb as well to find out the difference as well. Lower limb systolic blood pressure is always 10 millimeters more than the upper limb blood pressure. Okay, those are. Now, home recording of blood pressure, I have told you. Now, there are electronic equipment. You should train the patient how to record the blood pressure. Similarly, I have told you about 24-hour ambulatory blood pressure. The cuff is attached for continuously for 24 hours to a mission, monitoring mission, that is only recording the what is that computer chip is there. So it has to be put again into the computer and look for the graph 24 hours. What is the trend? Now, welcome. What is the indication of 24-hour ambulatory blood pressure monitoring? Not everyone requires the 24-hour monitoring. Now, if you have a patient who has got a very difficult to control hypertension, in spite of your treatment, patient is not getting controlled, blood pressure is not getting controlled, you can see that whether it is only the office hypertension or even at the home also the blood pressure to detect the white coat hypertension. Or you have a complicated hypertension retinopathy or a left ventricular hypertrophy, but when you record in the office, there is no blood pressure. Blood pressure is normal. But in other situations, he may be having episodic hypertension to find out that, masked hypertension to find out that. Or some people will have fluctuations in hypertension that are called as blood pressure variability. Like glycemic variability in diabetes mellitus, our blood pressure is maximum in the early morning hours. As soon as we get up, our blood pressure goes up. That is circadian rhythm. Sympathetic activity goes up. So there may be a sudden surge of blood pressure, systolic blood pressure. At night time, when you are resting at 2 a.m., after 12 to 2, the blood pressure goes very low level, at least 20 millimeters lower than the daytime BP. It is called as dipping of the BP, normal dipping, nocturnal dipping. So to find out all these things, we need the ambulatory blood pressure. Otherwise, routinely it is not required. Okay, fine. So this is what I have already described. The equipment should be regularly inspected and validated. Operator should be trained and retrained. Now, even though we are very well versed with recording blood pressure, we should practice recording very frequently, getting retrained. Okay. Now, we need to record at least 2 or 3 readings in the gap of 1 to 2 minutes, and take the average of the things. The first time recording blood pressure is always high. That is called as opening high blood pressure. And you record after 1 minute after, and another 1 minute or 2 minutes, more than 2 or 3 readings. And if there is a difference, you can take the average of the blood pressure. Okay. Now, it is not only recording blood pressure. Immediately you need to record the blood pressure, indicating the date, time, and location, whether the patient was in a painful condition, which position you have recorded blood pressure, whether the patient was in supine position, sitting posture, appropriate cuff was used, everything should be, and that has to be documented for the future reference. I told you that arm with the higher reading should be used for subsequent methods. So that has to be documented if there is a difference. Okay. Now, we brand the hypertension. We document or diagnose the patient to be hypertensive only if 3 readings of high blood pressure on more than 3 visits across 3 months. That is the standard teaching. Nowadays, they say that even 2 recording is also fine over 2 weeks. So that indicates that now I put it this scenario. A young person comes, 35-year-old person comes. The blood pressure on the office recording is 145, 140 by 85 or 85 or 88, whatever it is. Now, on 2-3 recording on the same day is that. Now, when I look for the cause of the secondary hypertension, there is none. When I look for the complication of hypertension, there are none. That means there are no features of target organ involvement, target organ damage, or no features of secondary hypertension, but there is blood pressure is likely elevated. I would not brand him as hypertensive right away. I will have to wait, call him again for weekly basis or monthly basis for several recordings. And in all recordings, if they're high, then only I will brand him as a hypertensive patient. Okay. Now, on the other hand, another patient with the same hypertension, 140 by 90 millimeters of mercury, or 146 by 96, whatever it is, but he has got evidence of left ventricular hypertrophy. Or when I look at the fundus, there are AV nipping. Now, that is the patient I say that you have elevated blood pressure and there are evidence of the target organ damage. There is evidence of target organ involvement or damage. Then even single reading of blood pressure is good enough to call that patient is hypertensive with target organ involvement or target organ damage. So they're all customized, tailor-made. Now, every patient, same blood pressure recording, one patient will not brand him as diagnose him as hypertensive, just elevated blood pressure, because we do not know whether persistent or not. Another patient may be diagnosed as hypertension on the basis of the target organ involvement or damage. Now, another patient comes with a blood pressure of 180 by 120. Even one recording, there are no complications. Still, I tell him that you are branded as hypertensive because it has come with the hypertensive urgency, very high elevated blood pressure without any problem. But he's a potential candidate to develop complication. So such patient should be diagnosed as hypertension. So there are different criteria, but the basic criteria is that persistent elevation blood pressure, 3 readings of high blood pressure above the cutoff values on 3 different occasions over 3 months. That to tell you that patient got persistent hypertension. The one more method is that 24-hour ambulatory blood pressure monitoring. Now, from the beginning, I'm telling that hypertension, uncontrolled hypertension can lead to the various cardiovascular morbidity and mortality. Now, who are more prone to develop such cardiovascular risk, stroke risk, or cardiovascular risk, myocardial risk? They are the person who are nocturnal non-dippers. I told you that when we record 24 hours recording between 12 to 2 a.m., the blood pressure should dip down to 20 millimeters, at least 10 to 20 millimeters than the daytime blood pressure. If that is not seen, in some patient, it may be reverse dipper, that the nocturnal blood pressure may be higher than the daytime blood pressure. In such patient, the the cardiovascular and stroke risks are much, much, much higher. Now we know that from day to time that there may be slight variation. Hypertension, blood pressure is a dynamic process. It will vary from time to time. The numbers will vary from time to time, circumstances, because the external factor, the first slide I have told you, blood pressure is also controlled by the external factors also. So depending upon the circumstances, blood pressure will vary. Now, if the fluctuation is very high, daytime to nighttime, early morning hours, variability is very high, that is also the risk factors for the development of the complications. Now, what are the corresponding values? If you record the clinic blood pressure of 120 by 80, now all those things, nighttime blood pressure by the ambulatory blood pressure will be approximately 100 by 65. That will be significantly less, 20% less. You can see that. Okay. Now, those are the different values. Now, what is important is that home monitoring of blood pressure, that is self-monitoring of blood pressure, is almost equivalent to the 24-hour ambulatory blood pressure monitoring. You can see that across the, even though clinic recording blood pressure and daytime monitoring of blood pressure is little higher, the home monitoring of blood pressure is almost equivalent to the 24-hour monitoring of blood pressure. Okay, fine. Now, I've told you that there is one entity called a isolated systolic hypertension. There is diastolic blood pressure will be still normal. Now, that is again important factor. Now, what is happening? Only systolic blood pressure is increasing. That is because of the arteriosclerosis. Whereas the diastolic blood pressure is little low. That means pulse pressure is increased. Now, we know that normal pulse pressure is about 40 millimeters plus or minus 10. Now, if the pulse pressure increases even by 10 millimeters, such people's cardiovascular complications are much, much more. Okay, fine. We have one variety called a white coat hypertension. I did mention about that. Because of the circumstances, the blood pressure in the office setup may be very high, maybe in the stage 1 or stage 2, whatever it is. But when they go out of the office setup, the clinic setup, the blood pressure become normal. That is called as stress induced at the clinic or the office. That is white coat hypertension. But they do not have persistent hypertension. They are not hypertension. They do not require any treatment. They require only biofeedback mechanism to control their stress. Okay. Then there is one more variety called as masked hypertension. Previously, I told you that the blood pressure may be normal in the clinical setup, but you get the clinical signs of the complication of hypertension. Now you need to suspect masked hypertension. You need to record there is a false finding of normal blood pressure during examination. Okay. Now, we need to subject such patient both white coat hypertension, masked hypertension to 24-hour ambulatory blood pressure monitoring to unmask this thing. Okay. Now, once we have confirmed that this particular patient has got hypertension, we have the patient evaluate. We have to evaluate. We have to look for, even though they may appear as a primary hypertensive, we need to look for other than a secondary component. We need to assess what are the possible reasons for the development of the hypertension. To assess the lifestyle, I can see somebody is exercising, eating, another thing. So we need to assess the lifestyle and identify other cardiovascular risk factor. Patient may be having dyslipidemia, patient may be having obesity, the truncal obesity, and so on. And other concomitant disorder, diabetes, chronic kidney disease, or anemia, many things which we need to identify the comorbid condition. And our objective in the evaluation should be to reveal the identifiable causes. Previously, I said hyperthyroidism, hypothyroidism, renal failures, and so on. To assess the presence or absence of the target organ damage and some of the complication at the given time. At every time, we need to look for those things. Now, whether this patient has got hypertension, true, but did he already develop target organ damage or target involvement like retinopathy, cardiac enlargement, cardiac hypertrophy, or proteinuria, and so on? Okay. Now, we can assess the cardiovascular risk factors, like American College of Cardiology and Heart Association has given the atherosclerotic risk stratification calculator. We can put in all the factors and calculate the 10-year risk of the heart disease or stroke. Probability of development of the complications in 10 years can be calculated by this simple software. Now, why it's important? Now, if the probability is very high, even if it is more than 10%, even at the lower level of blood pressure, we need to intensify the therapy. If the risk factor is little less, we can be on little less intensive on the pharmacological therapy. That is the importance. Okay. Now we need to do the thorough examination with the appropriate blood pressure, the pulse volume, the pulse pressure. I've told you all those things. The BMI we need to calculate to find out the obesity and other things, even the neck circumference, truncal obesity, all those things. We need to specifically look every hypertension patient. We should look for the apical impulse, the position of the apical impulse and the character of the apical impulse. The moment you get a high blood pressure and displaced cardiac apex, even if it's not displaced, heaving apical impulse, that indicates that this heart is being put on the stress for a long time, causing hypertrophy. That is target of involvement is already there. Auscultate carefully for the second heart sound, fourth heart sound, ejection murmur, crepitations, renomegaly, optic fundi, carotid or renal femoral bruise, thyroid examination, all those things. Now, with the clinical examination, you have the basic and optional laboratory in the evaluation primary hypertension. The blood glucose is mandatory, complete blood count is mandatory, lipid profile is mandatory for the beginning of the diagnosis of hypertension. Serum creatinine with the estimated glomerular filtration is also mandatory to begin with the diagnosis of hypertension and to find out the complications as well. Sodium, potassium, thyroid stimulating hormone, TSH, urine analysis to find out proteinuria, electrocardiogram. These are all mandatory tests for the diagnosis of the hypertension to find out the target organ involvement or damage, or the second pointers to the secondary things. The optional testings are echocardiogram, and there are many optional testings are available. And if you think that there is some possibility of secondary factor leading to the hypertension, aggravating the hypertension, you need to do the advanced investigation like renal Doppler, digital subtraction angiography, the thyroid function, cortisols, ACTH, catecholamines, VMAs, to find out all specific causes for the secondary hypertension. Okay. Now, once we have found out all the is hypertensive, there are no secondary causes, or but the target organs are involved or damaged or not, whatever we have to sort out, triate them. Then our goal of the treatment should be maintaining the blood pressure less than 140 by 90 millimeters of mercury, even for the age of less than 60 years. For the age of more than 60, the goal target of the maintaining the high blood pressure is less than 150 by, still they will be in the stage 2 hypertension as per the AHA guideline, but still the goal is that now. Now, if the patient is diabetic or hypertensive, the target value is 140 by 90, less than 140 by 90 millimeters mercury. Now, this is the AHA guidelines where still they define that hypertension is more than 130 millimeters mercury is hypertension. Still, their target goal of treatment is, because they have found out that even though blood pressure more than 130 can lead to the various complications later on, but controlling blood pressure to the very low level may not have much benefit. But in JNC 8, the target of the blood pressure, if they're diabetic or CKD, the target is less than 130 by 85 millimeters mercury. Now, our goal is to reduce the cardiac and vascular and renal morbidity and mortality. Correct any precipitating factor. If there is any dyslipidemia or thyroid dysfunction, we need to correct that. Okay. Now, again, AHA guideline says that normal blood pressure is less than 120 by 80 millimeters of mercury. Promote optimal lifestyle habits. I'll come back to that, and reassess once in every 6 months or every year. This says every year. If the elevated blood pressure between 120 to 130, non-pharmacological therapy has to be started. Okay, there is a class 1 indication, and reassess. So the person who has got blood pressure of 120 to 139 systolic blood pressure, we need to reassess every 3 to 6 months. That is important. Now, if the blood pressure is stage 1, that is more than 130 to 139 or 80 to 89 diastolic, now you need to assess the atherosclerotic risk factor, okay, cardiovascular risk factor. If the estimated 10 years cardiovascular risk factor is more than 10%, is not there, you can still maintain like in elevated blood pressure, or if there is a risk factor is there, you need to start them on therapy, drug therapy. That is the importance. Now, even if the patient is in the BP of 130 to 139 and the 10 years probability of cardiovascular risk factor is more than 10% by the calculator, then we need to intensify the therapy with the BP lowering medication. Okay. Then if it's stage 2 hypertension, yes, non-pharmacological therapy is required and BP lowering medication is also required. And we need to monitor every month, such patient monitor every month till you reach the target blood pressure. And if the BP goal is met, we can reassess every 3 to 6 months. If the BP goal is not met, we need to intensify the therapy and monitor them. Now, what is the benefit of treating hypertension? Controlling blood pressure, reduction in the stroke incidence by 35 to 40% when compared to those who are not controlled. Reduction in the myocardial infarction by 20 to 25%. So there is a clear-cut evidence that reduction of the blood pressure to the target reduces the complications, and reduction of the heart failure by 50% in future. Okay. Now, treatment options, we have non-pharmacological therapy, that is lifestyle modification, diet and exercise. And we have pharmacological therapy, that is various antihypertensive medications are available. Now, what are the lifestyle modification? Excuse me. What are the lifestyle modifications are available now? We have decreased time in sedentary behavior, such as watching television, playing video games, or sleeping, spending time online. So they're all simply sitting jobs. They're all very primarily tend to gain weight and primarily cause aggravated atherosclerosis. It increases the vascular resistance, so on. So promote physical activity such as walking, biking, aerobic exercise, tennis, soccer, any form of simple walking every day for about 40 to 50 minutes per day is good enough. They benefit in reducing the peripheral vascular resistance, thereby reducing the blood pressure. Decrease the portion size in the meals and snacks. Reduce the portion size in the frequency of the consumption of calorie containing beverages. All these things help in the reduction in the weight. Now it is said that there is something called a dietary approach to stop hypertension, DASH. A diet which is very rich in fruits and vegetables and reduction in the salt will help to reduce the blood pressure. Now, weight reduction of 10 kgs. If the patient is obese, you say that weight is 80 kgs, blood pressure is 160 by 100. If the person reduces weight by 10 kgs, his blood pressure can come down by 5 to 20 millimeters. Now, reduction of 10 kg of body weight can reduce the blood pressure anyway from 5 to 20 millimeters of systolic blood pressure can be reduced. So we need to maintain the body mass index between 18 to 24. That is very important. So that is very essential step in the non-pharmacological therapy, lifestyle modification. Now, DASH diet, consume diet rich in fruits, vegetable, low fat and low salt diet. The blood pressures can come down by 8 to 14 millimeters of mercury. Similarly, dietary sodium reduction in this dietary sodium intake, avoiding added salt, salt containing the biscuits, bakery items, they all can help reducing blood pressure. Physical activity, engage in regular aerobic activity and other things can reduce the blood pressure again. And moderation of the alcohol consumption, those who are alcoholics should reduce the alcohol consumption. They're also known to, now these are all the set lifestyle modifications which are recommended for every patient, not only to control the blood pressure, to prevent hypertension. Even those who are not hypertensive, if you adopt these things, lifestyle modification, the development of the blood pressure can be hypertension can be postponed or prevented. So this has to be adopted for everyone in their life. Now I have highlighted it. These lifestyle modification can bring down the blood pressure, by anywhere between 5 to 20 millimeters of mercury. It may act like taking one drug, but it is mandatory to prevent hypertension as well as to control hypertension. Okay, fine. Now we have various pharmacological options. I think I'll go on because there are moderator. Are there any sessions further ahead, or should I go on? Yeah, I'll go on. The pharmacological therapy, We have several type of the drugs. The current recommendation that the drug of first choice are diuretic, thiazide group of diuretics, and we have AC inhibitor, we have receptor blockers, angiotensin receptor blockers, calcium channel blockers. These are the drug of first choices. And drug of second choices, of course, beta blocker were the previously first choice. Now it has become second choice because of their lack of benefit of the various factors. The drug of second choice, which are usually used for the combination of drug therapy, are the sympathomimetic, centrally acting drug, direct vasodilators, and so on. Now, diuretic, especially the hydrochlorothiazide, the thiazide group of diuretic, which acts as the distal DCT, the sodium co-transporter. No, that is the one which is commonly used. Chlorthalidone and clopamide are the drugs which are used commonly as the drug of first choice that is recommended by all hypertensive societies. They act by natriuresis to some extent, and finally they act on the vascular endothelium. They finally reduce the peripheral vascular resistance. They do the vasodilatation. So that is the way of long-standing action of the drug. And we have plenty of the potassium-sparing diuretic, loop diuretics. Many drugs are available, but as a hypertensive, routinely as a first-line antihypertensive drug, the drug used is hydrochlorothiazide drug or thiazide group of diuretics. Okay. However, they have their own side effects. Will be the hypokalemia, dyselectrolytemia, hypovolemia, hyperuricemia, and these people who are on the hydrochlorothiazide or thiazide group of diuretic may have a slight elevation of the glucose intolerance, dyslipidemia, and so on. Now we know that renin, angiotensin, aldosterone system is the primary thing which modulate the peripheral vascular resistance. They help in the vascular the AT1 receptor will help cause the vascular hyperplasia or hypertrophy of the ventricle. They can cause the direct vasoconstriction. They can cause salt retention and so on. So we need to block that at different levels. Now we have the direct renin blockers as well. I'll come back to that. And we can block the conversion of the with the AC inhibitor. We can block the conversion of the angiotensinogen to angiotensin 2, thereby the further all these hyperplasia, direct vasoconstriction, or all salt retention can be blocked. Similarly, we can block at the receptor level, that is angiotensin 2 receptor can be blocked with the drugs, or renin at the stem itself, renin blockers are also available. Now AC inhibitors, there are several groups of drugs. Commonly we use enalapril or lisinopril and so on, captopril, which is not available now. And AERBs, we have plenty of TANs, losartan, telmisartan, olmesartan, and many of the drugs are available. Now all of them will act at these levels. Now, what do? They reduce the blood pressure they reduce the afterload. Why? They regress the hypertrophy of the myocardium. They regress the peripheral vascular, they reduce the peripheral vascular resistance. They have got a glomerular protection. They improve in the salt and water balance. In multiple actions, they act at multiple levels and cause reduction in the peripheral vascular resistance and reduction in the blood pressure. So they have been named as the class 1 indicators of the hypertension in young patients, especially in blacks. Now, all the drugs will have their own side effects, the impaired renal functions, hyperkalemia, significant postural hypotension, because of the bradykinin degradation, they can produce significant dry cough and angiogenetic edema. These group of drugs are definitely contraindicated in the young women, especially the pregnancy 100%, but you should be extra cautious in initiating AC inhibitor and ARBs in a young women of the childbearing age group. Suppose if they get conception, they have conception, they can induce intrauterine death. Okay, so it can induce first trimester abortions. So the pregnancy is definitely contraindication. So all women of childbearing age group, it is better to avoid in prescribing AC inhibitor and ARBs. Similarly, hyperkalemia, very high creatinine level, renal artery stenosis, the presence of angiogenetic edema, all those things are contraindication for the AC inhibitor and ARBs. Beta blockers are the next group of drugs which are commonly used. The hybrid beta blockers are now preferred to the selective or non-selective beta blockers. The hybrid beta blocker, when we say they have both beta and alpha effect, like in carvedilol or nebivolol, they have the beta 1 effect and nitric oxide donor effect. So the peripheral vascular resistance is reduced there. And if you use the isolate beta 1 effects, the metoprolol and bisoprolol, the common drugs. Non-selective drugs like propranolol, metoprolol are not commonly used as antihypertensive drugs. Now, they reduce the force of action, they reduce the heart rate, and they also reduce the renin secretion. Those are the ways of the methods of the, but they can increase the peripheral vascular resistance. That is why the carvedilol or nebivolol are a preferred drug of antihypertensive with the beta blockade action currently. Now, the compelling indication, now they are not the class 1 indication or the drug of first choice. There are some compelling indication to start the beta blockers. If a patient who has got hypertension with the angina or post-myocardial infarction, or person with the chronic migraine where prophylaxis is required, in such cases only the beta blockers are commonly used nowadays. Now, there got plenty of adverse reactions like from the bronchospasm to vasoconstriction, peripheral vascular disease. It can worsen the lipid profile. It can mask the hypoglycemia. So it is not used in the diabetes. It can worsen the heart failure and so on. There are so many adverse effects of that. The one more group of drugs we all are aware that the calcium channel blocker, again, the drug of first choice in the elderly people as well as in blacks. In 60% of the Indians, the calcium channel blockers work best. They do their job well. The dihydropyridine groups, especially the amlodipine or nifedipine sustained release tablets. There's so many drugs are available. Primarily, non-dihydropyridine groups are not used as antihypertensive therapy. They are all used for the rate controlling of the some. Now, there are so many generations. The generation nothing but they have got extended release formulations and something like that. There is nothing much new on. The nifedipine extended release or sustained release formulations are used, and amlodipine. Currently, cilnidipine are the drug of calcium channel blocker of choice currently being used of their beneficial effect. Their effects, some of the adverse effects are peripheral edema. Because of the vasodilator effect, they tend to leak fluid into the interstitium, causing peripheral edema. They can induce significant postural hypotension. They can cause tachycardia. So those are some of the adverse effects, but still they are commonly used. The other drugs like alpha blockers like prazosin, doxazosine, terazosin are all used. The compelling indications are the men with benign prostatic hyperplasia, or in a patient who got resistant hypertension, we know the add-on drugs. The central sympatholytic or atocentral drugs like methyl-dopa, which is commonly used in the pregnancy-induced hypertension, pre-eclampsia toxemia and such condition. Otherwise, they are rarely used because of their toxic profile, the side effects. The reserpine, again, because of their rebound hypertension, they are not commonly used now. But for knowledge, we should know. The direct vasodilators like dihydrolysine and hydrolysine are still used, minoxidil, or are used still now for the treatment of resistant hypertension alone, but not as a drug of first choice and not even the second choice. Okay. Now, as I said, in the renin-angiotensin cascade, there are direct renin inhibitors. Now, when new groups have come, eliscarin, they are the first available peroral. They decrease, they prevent the cleavage of the renin. Thereby, they cannot cleavage the angiotensinogen to angiotensin. Thereby, they block the renin-angiotensin cascade. They have the same effect as AC inhibitor and ARBs. Okay. Now, we may have to use the combination of drugs. The combination which should not be used are AC inhibitor and ARBs together because they work in the same axis. Beta blocker and AC inhibitor should not be used because of the potential hyperkalemia and the complications. Okay, so other combinations have AC inhibitor or ARBs are combined with the calcium channel blocker. They got potentiating action, or with the diuretics, hydrochlorothiazide or chlorothiazidone. There's very good combination. Similarly, beta blocker and calcium blocker also commonly used combinations. Now, even the recent AHA guideline says that consider initiation of the pharmacological therapy for stage 2 hypertension, that is more than 140 millimeters of mercury, 140 millimeters of mercury, systolic blood pressure, or 90 millimeters diastolic blood pressure, with the 2 antihypertensive agents of different classes should be used for the better optimum controlling of blood pressure, better optimum early controlling of blood pressure. So different patients require different treatment. You have to tailor the things. Pre-hypertension or elevated blood pressure, you need to intensify the lifestyle modification. Even in non-hypertensives, we have to recommend, motivate the patient to continue the lifestyle modifications, adopt the appropriate diet and lifestyle modification to prevent development of hypertension and to control the pre-hypertension as well. Stage 1 hypertension, we need to have intensified lifestyle modification and ideally with one drug. But in stage 2 hypertension, we recommend the lifestyle modification, intensification, and combination of drug therapy. Okay, but it is not definitive. It is a custom-made. Treatment is personalized and tailored. And even in given patient, because the blood pressure can go dynamically, the hypertension go to different stages in and out. So we may have to customize the therapy very often. Okay. Now these are the things. Drug therapy for everyone with the blood pressure of more than 140 by 90 millimeters. Okay, fine. That is the current recommendation. Now, compelling indication, young patient with hypertension, beta blocker, AC inhibitor, or ARBs. Now, still in India, we still use beta blocker for the young hypertensive. But in the AHA guidelines, we need to use the either diuretic or the ARBs. Elderly blacker hypertension, we commonly use calcium channel blockers. They work best. Hypertension diabetics, compelling indications are AC inhibitor and ARB worldwide. And hypertension with ischemic heart disease, beta blocker is the compelling indicator. Hypertension with migraine, again beta blocker. Hypertension with BPH, alpha blocker like prazosin is the compelling indication. Now, untreated hypertension can lead to complications. We all know that it can induce stroke, it can induce left ventricular hypertrophy, which we can pick up by the heaving apical impulse of allowed A2 or S4. That's the clinical indications. Heart failure like elevated JVP, hepatomegaly, edema, basic Crips, LVS3. Coronary artery disease like patient may have the angina, unstable angina, or myocardial infarction. Cerebrovascular disease may be like they may manifest with the TIAs. They would have already had a stroke and recovered from that, or peripheral neuropathies. Peripheral vascular disease like accelerated atherosclerosis, peripheral vascular occlusive disease, nephropathy like microalbuminuria or CKD. These are all the complications which tend to develop in a progressive way, dynamic way, in uncontrolled hypertension or untreated hypertension. Okay, fine. Now, retinopathy is the one common thing which can easily detect. You can look at the vessel. With your direct ophthalmoscope, you can directly look at the retinal vessels. What happens? We know that what changes develop in the small vessels. The arteriosclerosis will develop. The stiffening of the vessel can be seen. The arteries, normal retina, will see the veins are little larger than the artery. They run parallel to one another from the disc. Now, in the stage 1 hypertension, the artery becomes stiff. They become silver wiring, something called as silver wiring will be there. Arterial narrowing, segmental arterial narrowing may be like this. Okay, that is what stage 1. We know that even though blood pressure is 140 by 90, if this is there, we know that this patient is having long-standing blood pressure. He need to be intensifying lifestyle modification and therapy. This may be just involvement, maybe reversible factor. Even stage 2, the thickened arteries, tortuous artery is compressing, crossing over the vein, retinal vein called as AV nipping. It is compressing the vein. There is a dropout in the venous segment there. So this is very classical stage 2 hypertensive retinopathy. Still, even this stage, if you can control very good, it is reversible stage. You can reverse this stage, and the other complication can be prevented if you recognize at this stage. And if it advances, it can lead to the hemorrhage. It can lead to the protein leak and causing the exudation. And this is the reversible stage. And further, the patient may develop papilledema. Again, the eyesight may be lost, retinal detachment may be there, advanced things can develop. So there is different stages of, we can be at bedside, we can assess this complication very easily. Now, there is some more complication like crisis. There are two things very commonly asked question: hypertensive emergencies, or previously we called it accelerated hypertension, or hypertensive emergency, previously it was called as malignant hypertension. Now, hypertensive urgencies are said in a patient who does not have target organ damage, but blood pressure is very high, more than 180 by 120 millimeters of mercury. Any one is possible. Patient may be having systolic blood pressure more than 180, but diastolic blood pressure may be less than that. So target organ involvement may be there, may not be, but there is no ongoing life-threatening damage is not there. Those are the urgencies. Why? We need to control the blood pressure to the reasonable targets in about 24 hours. We need to bring down the blood pressure in a gradual fashion. 10% of blood pressure should be reduced in 24 hours. Okay. Now the common thing is that elevated blood pressure with headache, elevated blood pressure with the left ventricular hypertrophy, heaving apical impulse, or elevated blood pressure with the angina, microalbuminuria, all these things comes under urgency category. Now we need to bring down the blood pressure by 10 to 24% by another 24 hours. We can give oral drugs, change the medication, add on the medication, monitor very frequently, see that they do not develop more complications. Okay. Ideally in the hospital setup, they have to hospitalize and monitor very frequently. And that is very commonly asked 5 marks question for the UGs. Hypertension emergencies, very high blood pressure, more than 180 by 120, but there are something life-threatening complications ongoing. With progressive target organ damage is ongoing, like intracerebral bleed or pulmonary edema with very high blood pressure. We need to bring down the blood pressure very rapidly, drastic requirement, rapid within few minutes to hours. The rapid requirement of the lowering of blood pressure is required there. Okay. Hypertension encephalopathy or acute left ventricular pulmonary edema, myocardial infarction, unstable angina, such conditions. Okay. In such condition, we need to use the intravenous drugs to lower the blood pressure, like intravenous furosemide, labetalol, enalaprilat, nitroglycerin, or sodium nitroprusside. The various drugs has to be. Now, details I'm not going into the details of the treatment of hypertension emergency, but this nutshell, this is the summary of the thing. Now, there is a triple paradox of the hypertension. Now, we have learned about what is hypertension, how to detect hypertension, what are the precipitating factors, what are the secondary causes of the hypertension, how to look for the secondary factors, when to diagnose, what are the methods, office blood pressure, home blood pressure, and the 24-hour ambulatory blood pressure, where to apply them, what are the basic evaluation required, how best to implement the lifestyle modification, what are the drugs, basic drugs available for us for the first choice, second choice, and combination therapy. In spite of all those things, we know that it's very easy to diagnose, isn't it? With simple recording of blood pressure and simple things, we can recognize the high blood pressure, hypertension, and its complications. We can recognize very easily. But 40% of hypertensive are still undetected to be hypertensive. They are not aware, they're not detected in the community, in the population. We know that even after diagnosis, very easy to treat hypertension. With lifestyle modification, we can reduce the blood pressure by 10 millimeters. Adding on 1 drug, 2 drugs, 3 drugs, we can reduce the blood pressure. But simple to treat, simple to monitor. But still, even those patients who are diagnosed to be hypertensive, 40% remains untreated. Okay, they do not tend to take the medication, or they do not comply on the lifestyle modification. Because why is that? My blood pressure 150 by 100. I am happy. I do not have any pain now. Why should I bother? It is a painless disease. So they tend to in spite of knowing that they are hypertensive, they tend to ignore it. We need to educate the patient, monitor the patient, counsel the patient, motivate the patient to modify the lifestyle and to consider antihypertensive therapy for the patient's benefit. Okay, that is the prevention of the complication. Many drugs are available. We have many drugs, but still, even those small chunk, maybe 1/3 or 1/2 of the patient may be willing to take the medication. In spite of using the drugs, only 40% are not adequately controlled to the target. We know that what is target? Less than 140 by 90 millimeters mercury, in spite of using the drug. So there is a triple paradox. Easy to diagnose, but 40% remain undiagnosed. Is simple to treat. In spite of treatment, 40% of untreated. In spite of treatment, those in the treatment treated category, 40% remains inadequately treated, not to reach the target. So that is called a triple paradox of the hypertension. We need to break this to prevent the cardiovascular morbidity. Okay. Now, how to prevent hypertension in you and me? Everyone, we need to, from the childhood, we need to motivate this to prevent the development of hypertension in the middle life, young adults. Okay, lifestyle modification, maintain the healthy weight, reduce the salt and sodium intake, increase the physical activity, simply walk, jog or aerobic exercise. Anything is good to prevent hypertension. Smoking has to be abandoned. Cessation of smoking should not be started. If it is started, it should be stopped. Limiting of the alcohol consumption, limit the fat intake. They're all very good. Controlling of the comorbidity, like controlling of diabetes, stress relieving techniques like yoga, biofeedback mechanism. And if the hypertensive, take the BP medications as ordered by the doctors. That has to be counsel to the patient, re-emphasize to the patient, and emphasize the patient to monitor the home BP. Even those who are not hypertensive, it is always wise to record the blood pressure. At least the patient who was coming to the clinic or the office for any other reason, let it be for fever, cough, let it be for headache, for any reason they come to the hospital, you should record the blood pressure. Monitor, record, and hand over that this is your recording. You need to record every monthly or every 3 months periodically. It has to be emphasized to the patient to prevent the development of hypertension or control the hypertension. Okay, fine. So stay safe, stay healthy. Thank you all. Now, so that is in brief about hypertension there. Okay.
Thank you, sir. Sir, there are a few questions in the chat section, sir.
Yeah, I will go through that.
Yes.
There are many drugs in each class. Which drug to choose from each class? Now that is individual. Now the first, I think that is the first question, or is in the class. How do I go? Okay, one second. How do I explain it? Can you zoom this? Okay. I think there are 3 questions there. There are many drugs in each class, but which drug to choose from each class? Like ARBs, we have losartan, telmisartan, well, there's so many sartans, but that is individualized. There are no difference between the group. There are so many studies saying that this drug is slightly better, but whatever the drug used one group of drug among them, anything is good. Losartan is equally good to the telmisartan, but most of the drugs should be used at the night time. Most of the antihypertensive drugs, unless diuretics, most of the drugs should be used in the night time, because we know that morning surge should be prevented. So the nighttime drug should be best used. All antihypertensive drugs should be used at night time. Can beta blockers be used with the people having bronchial asthma? Ideally, no. Bronchial asthma is a relative contraindication for the use of the beta blocker, because they have got the bronchospastic action. But the current drugs, metoprolol, carvedilol, they do not have the significant bronchospastic effect. They can still be used. What are the drugs dosage and what should be known as MBBS pass out in what are the drugs dosage? Okay, drug dosage is not very significant, that you can, for individual group, like if you use enalapril, 5 milligrams to be start, 2.5 to 15 milligrams can be started. If you want to start the atenolol, 25 milligrams to 150 milligrams of the drug, that is all you come to know the individual dosages. Okay. Does the arteriosclerosis cause hypertension? It is a two-way. Both things. Arteriosclerosis, aging process can produce hypertension, and hypertension also can aggravate the arteriosclerosis. That's two double-edged swords. Hypothyroidism, because of the thyroid mechanism, the what is that, endocrine axis, the basal metabolic risk comes down, the vascular tone increases, they can induce endocrine hypertension. Okay. Then, sir, if the patient misses take the medication for 1 day, what is the complication? There are likely, now there's very common thing, they tend to skip the medication. The chance of blood pressure suddenly going, rebound hypertension is very high. In such condition, the complication is also high. But it is always wise to take the blood pressure medication at the periodically, at a specified time, irrespective of the food. If somebody is taking blood pressure medication at 10 p.m., they should take it at that particular time every day. Okay. Yes, again, hypothyroidism, they're all in the first, the thing I have told you, that pituitary adrenal axis, everywhere thyroid hormone acts. They can derange the adrenal axis. They can finally lead to the peripheral vascular resistance and salt and water retention. They all can cause the hypertension in the endocrine disease. BP below 120 SVP is considered normal. But what about hypotension? Now, there is no lower cutoff. The systolic blood pressure less than 90 is said to be hypotension. Some people may have 90, they're happily living. But normally 90 to 110, 120 are normal range. Okay. But hypotension is also important. Less than 90, mean arterial pressure less than 60, where the organ perfusion is decreased, that can lead to the complication as well. Maximum how much salt can be taken by a hypertensive? It is said that added salt, we measure the salt by grams every day? Every food item will have salt. So you need to ask them to reduce the salt intake. The salt in the cooking has to be reduced. We can say 2 grams, 3 grams, but it is not practical. We have to ask them to cut down the salt intake by half of their previous value. The cooking salt also has to be reduced. The added salt diet are the usually bakery items, the fried items, that has to be stopped. Okay. And some of the high sodium contained the beverages, canned items, stored items, which classification BP is preferred now? The classification is that primary hypertension, secondary hypertension, that is standard. Staging of hypertension, JNC 8 is still gold standard. That is still used widely. Now, of course, now with the, I cannot say the pharmacological companies, no, we know that when we want to start the hypertensive medication at 130, 140 level, we are using more and more drugs. So there we are selling more and more drugs. So we do not know which is right, which is wrong. Time has to tell us at what level we are. But currently we start antibiotic medication, anyone who has got target organ involvement, if the blood pressure is more than 140. If the target organ is not involved, we still recommend non-pharmacological therapy and monitor them frequently. And if the blood pressure is more than 150 by 90, and we have to start the medication. During the fast, can we take medication? Yes. No, even on the fasting day, the blood pressure will not vary significantly on dietary thing. Even on the fasting day, blood pressure medication has to be taken. Any effect of hypertension medication on diabetic patient? Yes, they're all interrelated. The best drug which prevents the diabetic complication, renal complications, are the AERB or AC inhibitor. So that are the drug of choice in a hype. That is a compelling. If the patient is impaired glucose tolerance, he has diabetes, the drug of choice should be AC inhibitor and or AERB. Okay. What is significance? Time during intake of tablets, sir, irrespective of the food? Yes. No, I have told you that there is something called as blood pressure variability. In the 24 hours, the lowest blood pressure between 12 to 2 p.m. to midnight a.m. and then gradually tend to, because of circadian rhythm, they tend to raise early morning, 4 a.m., 5 a.m., 6 a.m. Suddenly we get up, the blood pressure surges. We know the half-life of the tablets. Yeah, I say, suppose I take the atenolol in the morning, till next morning, the adequate dosage may not be there to reduce the blood pressure. So the blood pressure surge may not be controlled. So if I take the same drug at night time, it will be in the middle of the half-life. The drug will be acting best. The surge can be prevented. So complication can be prevented. So the timing of the blood pressure medication should be at night time, preferably same time. On the first sitting of the BP, sorry, I'm not unable to scroll it down. How do I scroll down?
So you can try stopping the screen share, so then you might be able to do the chat as full screen.
Okay. I stopped it. Okay. Now. No.
Seconds.
because the message has passed. Okay, anyway, the last message, is there any age bar to start antihypertension? No, it is not any age. The cutoff value for that age, whatever the age, if it is more than the cutoff value as per the ANC guideline, the JNC guidelines, or the whichever you adopt, you should start the antihypertensive medication. Due to action sympathetic activity, nervous venous drainage increase. Sorry, pheochromocytoma is a specific hypertension. So that is a separate expand. Okay, fine, I got it. Still save chart. I'm unable to read the complete question because I'm not unable to expand the chat box. Okay.
So shall I read the question, sir?
Yeah, please.
Sir, after the any age bar, so the next question is how to control hypertension in CKD with high creatinine and urea with breathlessness.
Okay, now you are obviously talking about a patient with CKD, and the patient has got fluid overload. There is renin-angiotensin system is blocked. Now there is problem of hyperkalemia. So in such condition, a patient who has got creatinine of more than 3 or CKD, that is stage 4 and on, creatinine clearance of less than say about 40 ml per minute. Now, such condition, we should not use AERBs and AC inhibitor. We should control with other drugs like calcium channel blockers are there, diuretics are available. So they can use with the other drugs. And it is very difficult to control because there are so many mechanisms playing in the chronic kidney disease, not only the sodium water retention, the increased peripheral resistance, renin-angiotensin axis, and we may be giving the erythropoietin so frequently. So they're all contribute to the development of the hypertension. Those are the people, or there may be secondary renal artery stenosis. So there's so many things in the chronic kidney disease. So they all tend to develop resistant hypertension. Of course, I did not mention on resistant hypertension. If you use appropriate 2 drugs or 3 drugs, including diuretics, combination drug in optimum dose, still if the blood pressure is not controlled to the target, then it is called as resistant hypertension. It's very common in CKD conditions or in the secondary hypertensive use.
So next question is, can beta blockers be used in people having bronchial asthma?
I think that, yeah.
If patient knows the triggering factor of asthma and he prevents that.
Sorry? Hello? Yeah, beta blocker, I've already, I think, discussed with this. Ideally, beta blocker like non-selective propranolol and atenolol, relative selective beta blocker are not indicated, relative contraindicated. But the latest, the hybrid beta blockers like carvedilol, labetalol, they do not have much of the respiratory bronchospastic effects, though they can be safely used. Okay, they will not produce any problems. Even metoprolol, for that matter, asthmatic, they may not have significant bronchospasm. That is, we have to tailor. If they have developed bronchospasm, we caution them, give them if a compelling indication. If they develop complication, we withdraw that. That's it. Otherwise, they can be used. They are relative contraindication, not definitive contraindication. Anything else there? Hello?
Hello, sir. One more question. Which is more dangerous, raised SBP or raised DBP?
Okay, now that is been studied very well. Now, there has been strong evidence saying that elevated systolic blood pressure is much more dangerous and contributing to the cardiovascular as well as stroke than the diastolic blood pressure. So the elevated, that is what they said, pulse pressure, increase in the pulse pressure, isolated systolic hypertension and elevated systolic blood pressure are the more dangerous than the diastolic blood pressure. Okay.
Sir, one more question, sir. Which is the cause for isolated raised diastolic hypertension?
Now again, I have told you that diastolic blood pressure in the first slide, I think I have told you that diastolic blood pressure is the arteriolar resistance. So when you have the small vessel disease, small vessel arteriosclerosis there, that reduces the diastolic blood pressure. Okay, that also can cause the problem. Whether it's systolic or diastolic doesn't matter. Both will create problem, but more problem is created by the systolic, elevated systolic blood pressure.
Sir, one more last question, sir. Timing the dose at night, will it not cause fall in BP during waking up?
Now, that's what I think I have explained it. There is a circadian rhythm in our normal blood pressure that will be maintained even in hypertensive. Even in a normal person, early morning, at the wake up time, because of sympathetic activation, there will be surge of blood pressure of about 10 to 20% of the other time. If you take the blood pressure medication at night time, in a hypertensive, that surge can be prevented. Now, we all know that all strokes, most of the strokes and myocardial infarction occur in the early morning hours. That is related to this nocturnal early morning surge. Our primary aim is to prevent the complication and the mortality and morbidity. Now, when we know that this surge is producing morbidity and mortality, we need to curtail that. The BP variability has to be brought down. In a minor population, if you use extra dosage, higher dosage, it may cause slight postural hypotension, especially in a alpha blocker. When we have a patient with a prostatomegaly and hypertension, use a bedtime dosage of the prazosin, it may produce postural hypertension. Similarly, AC inhibitor may produce postural hypertension. But we should warn the patient. But postural hypertension can be tackled with the warning, gradual getting up, waiting for a few minutes and standing, and so many things we can guide the patient. But surge we cannot prevent. So early morning surge can be prevented by only with the nighttime dosage, so that the complication can be prevented. Okay, that's all related to the BP variability.
Yes, thank you, sir.
Yeah, fine. I think I have just given the only basic idea, not very elaborated thing on any of these things. These are all broad understanding of what is hypertension, what are the types of hypertension, what are the stages of hypertension, not to confuse the treatment and the thing, and basic guidelines on the treatment and targets, and what happens if the untreated hypertension complication. Very basic things so as to understand for the basic UG level. Okay, it is not a extensive specific targets of the hypertension. Okay. Anyway, thank you. Stay healthy. All of you prevent hypertension yourself by adopting healthy lifestyle. Wish you all the best.
Thank you, sir. Thank you for the discussion, sir. Thank you, sir.
Bye. Good night.
Bye, sir. Good night.